Just going to wait a few more seconds, just letting people trickle in here for a sec. Okay. Welcome, everyone. Thank you for joining us for today's webinar with Dr. Kristal Rama on naturopathic approaches to autoimmune diseases. My name is Leanne Boucher. I'm the Territory Manager for BC, Alberta, Manitoba, and Saskatchewan. Today's webinar will be recorded and sent out to all registrants following the live presentation. You can download today's handouts from the top right of your screen. And for those that stay on for the duration of the webinar, you will have a chance to win one of 4 gift cards. So watch for the secret words and at the end of the webinar, you will be redirected to the contest entry page. Any questions that you have can be put in the Q&A on the right hand of your screen, and they'll be answered at the end of the webinar. Dr. Kristal Rama's fascination with science and resilience of the human body began at a very young age. Through observing her own body's responses to exercise and injury, she was inspired to obtain her Bachelor of Science in Kinesiology at Simon Fraser University. After working in various return to work and rehabilitation programs, she realized that her passion is in helping individuals live dynamic and vibrant lives, free of barriers, injury, and illness. In 2019, she completed her naturopathic medicine training at the Canadian College of Naturopathic Medicine, Boucher Campus. Today, her practice is built on 4 foundations: compassion, inclusivity, effectiveness, and sustainability. She is devoted to getting to the root of a health concern, empowering her patients with knowledge, and creating an individualized plan to help shift the body back into balance. I now welcome Dr. Kristal Rama.
Thank you, Leanne, for that wonderful introduction. I'm so grateful and so excited to be here today to talk about this topic. Naturopathic medicine has so much to offer autoimmune conditions, and my goal for today is to make this presentation as clinically relevant as possible and focused on case-based learning and hopefully some information and tools that you can take into practice right away or next week based on what we talk about today. So we'll be looking at a lot of labs today as a little bit of a caveat. For those of you who don't know me, I just wanted to take a moment to introduce myself further. I practice at the Family Health Clinic in Langley, BC. I sat on the BC ND board for 2 years. And as Leanne mentioned, my focus for patients is autoimmune conditions, but also digestion and stress and women's health, a lot of skin and pediatric health as well. And the 4 foundations that will really come up a lot in the presentation today are compassionate and inclusive medicine, as well as effective and sustainable solutions for patients. Before I move forward, I do want to acknowledge that I am here today on the unceded traditional territory of the Sumas and Matsui First Nations, and I am both grateful yet also conflicted to be here today on this land. The only disclosures that I have to reveal are that I am contracted by Life Labs today to discuss how I use their testing in cases, particularly in autoimmune conditions. And before I get into the first case, I just wanted to kind of set the foundation for how I approach autoimmune conditions and what are some key questions that I'll often ask patients right at the get-go. The one question that I always ask in any autoimmune disease case is, what was going on for you at the time of your diagnosis? Or if there's no current diagnosis, but I suspect an autoimmune disease, I ask patients to tell me about their stress from a scale of 1 to 10, 10 being high. And then I keep going. I say, what are the other sources? And I provide cues where needed. What about finances? What about relationship? How is your home environment? And then I'll often ask, what are the tools that you use for stress? And then the last question that I'll ask is, do you find that those tools are adequate, or do you find yourself often overwhelmed by stress? And there's 2 reasons for that. One, I want to ensure that I'm not contributing to their stress with a complex plan or, too many visits. Maybe we're maximizing visits and we're spreading them further apart so that there's no financial stress. And it also allows me to identify the barriers to cure. So when I'm looking at a patient, I'm always looking at the healing triangle, and particularly in autoimmune cases, really looking at where are they weighted? Is it in the mental sphere where they're worried about getting back to work, and I need to provide a medical note to take that stress and that burden off of their mind and say, we're going to get you there, but for right now, the body is asking for rest? Is it that I need to manage their pain? Is it that they're worried about what this means for their life and the prognosis, and we need to talk about acupuncture or counseling or EMDR or nervines or an emotional freedom technique to kind of help them manage their stress? And I would say that the two pieces that I'll often try to manage first, right off the bat, if they are present, are pain and sleep and the nervous system. Because if a system is in pain, or if a patient isn't sleeping with that has an autoimmune condition, where everything that we do after that just isn't going to land the same way as if those two pieces were there. So my goal is always to look at those two pieces and always look at where they're weighted. And often in my practice, I will follow the therapeutic order, but there are times, particularly in autoimmune disease, where it's actually important to jump the rungs and to potentially prescribe to help manage pain, or to do something that's a little bit more pharmaceutical to help with sleep, because it's as if everything you do after won't be touching it with a 10-foot pole. It will land so much more because their system is safe and their body knows that they can be in that state of healing. So that parasympathetic state and that lack of inflammatory pain state are often two pieces that I'll look at and that are really, really important to manage. Now we'll get into the cases. I'm so excited about these cases. So this first case was a 35-year-old male that had two chief concerns, his weight and also fertility. So I was actually treating his wife at the time for fertility concerns. And in heterosexual couples, I'll always ask to see the partner because it is sperm and egg, but also because at this time in many patients' lives, they're ready for change and accepting of change and very motivated. And many times I find in heterosexual couples, the male partner may not have even seen a doctor prior to this time, may not have had basic blood work. And there are multiple times now where we found autoimmune conditions because we got them in the door. So this was the case for this particular patient as well. So his chief concern with weight was that he does a lot of physical work and he gets very fatigued. He consumes a lot of food and meat, but it doesn't seem to stick, is what he reported. His thyroid had never been checked, but there was no family history of thyroid concerns. No travel with gastroenteritis, so food poisoning or any parasitic infections. And he wasn't able to report what his last weight was, just that he couldn't gain weight. And just looking at him, he had a small build, which he reported was really consistent with family history. His brother happened to be a jockey, actually. But I did notice that his voice was very hoarse and shaky. Other relevant history in this case was that his digestion was off. So he reported a lot of gas. Bowel movements were 3 times a day, but they really varied in consistency. I always show patients the Bristol stool chart because I have found over time that their verbalization of their bowel movements aren't always what I interpret it as. So I would like to see what they point to, and that way we're both clear on what that looks like. So he reported a Bristol stool chart type 6 for bowel movements, but no pain, no blood, no mucus, no undigested food, just these loose bowel movements. His energy was good aside from being a bit low in the morning. And his stress was really low, which is great. Again, I always ask about that if I suspect an autoimmune condition. And he reported that he was often cold. On physical exam, what I found was that his skin was warm and moist to touch. And I did a cardiovascular exam because at this point, I was actually thinking that he might have Graves' disease with the loose bowel movements, with the hoarse voice, with kind of the moist, hot skin. A lot of his picture, not able to gain weight, seemed in that hyperthyroid sort of diagnosis and in parallel with what we would maybe expect in a Graves' condition. His thyroid exam, though, was normal, so no enlargement, no bogginess, no nodules, trachea was midline. And because he hadn't had basic blood work done, and because I like this particular case of fertility and seeing the male partner in heterosexual couples to kind of look at all aspects of health and maybe be preventative of certain things, we decided to do a healthy living assessment. My diagnoses at the time were specifically that he might have Graves' disease with a differential diagnosis of microscopic colitis, as well as generalized anxiety disorder, as well as type 2 diabetes. So I ordered the healthy living assessment with the addition of a free T4, just again, thinking along that lines as I want to get more information about the free T4, the full thyroid picture, and the free T4 would give me that. And we're also not able, unfortunately, as naturopathic doctors, to order the thyroid receptor antibody test. So these were his labs. So his hematology looked excellent. His differential looked excellent. His fibrinogen was okay. One thing to note is that, of course, this has changed now with LifeLabs testing. So fibrinogen has been removed, and what it's been replaced by is magnesium. His serum iron, so the iron that's floating around in the blood, was good. His transferrin, which is that carrier protein, is also good. And his iron saturation, how much his body is saturated with iron or grabbing onto iron, was also good. But in this panel, you can see that his ferritin was low. So this number in a male of his age is something that sort of signaled to me that it's an amber flag, like let me know that we need to investigate this further. His blood sugar was good, so there was no need to kind of investigate that further. His hemoglobin A1C was good. All of his lab markers with respect to kidney health and liver health were also good. There were no issues. Again, that's the last little bit of his liver panel. There was no issues with his cholesterol panel. And to my surprise, there were no issues with his thyroid. So his T4 and his TSH were also good and very low inflammation, really, really low inflammation. So based on this, at his follow-up, I clarified a few things and I said, okay, you mentioned that you do eat meat. How much do you eat? How much meat do you eat? And what type of meat? And he said it's about 4 times a week. It's not red meat, it's mostly chicken. And then I screened for a couple other things to see where potential blood loss could be happening. So he mentioned that there's no history of a stomach ulcer or a gastric bleed, no chronic use of NSAIDs, no previous bleed at all in the GI tract. And I said, okay, I want to do an abdominal exam. And prior to doing an abdominal exam, he lifted up his shirt and showed me this rash. So this is dermatitis herpetiformis on a person of color. And this was a really important lesson for me because maybe had I not had all of the history and the labs at this point, if I saw this rash on the anterior and posterior thorax, I don't know at this time that I would have necessarily thought right away that this was dermatitis herpetiformis. And in school, many of the skin conditions that we learned about were on white skin. So it was a really good lesson for me to sort of really diversify the resources that I'm looking at when it comes to a skin condition and looking at it on various different types of skin color. So I said, I likely know what's going on here after the physical exam, and let's move on to the next step. I guess the other thing that I would say is that physical exam, particularly in autoimmune cases, have helped me so many times to find the cause of these unusual or abnormal symptoms that have gotten dismissed at the ER or prolonged with a patient's family doctor. And that isn't a knock on that. That's just that taking the time and being the doctor that's thorough has really helped to put the pieces together for me for a patient and their case and what's happening specifically. And there are 2 resources that will be at the end on the last few slides about looking at skin conditions on different people of color. One of them is called DermNet. It's quite good, I would say, at showing a skin condition in various different colors, and it's quite a big database of different skin conditions. And then also the other sort of thing that I did after seeing this case is I started following Brown Skin Matters on Instagram. it's just, as you go through your feed, it's just another way of getting exposure to how the skin condition looks on black skin or brown skin, and is now in my repertoire of thinking about skin sort of in a different way, and making sure that I don't miss diagnoses because of my own biases or the availability bias of certain skin conditions. So for the follow-up testing, we decided to go ahead and do a FIT test. The reason for this is because, yes, it very likely was celiac disease, but I did not want to miss a colorectal cancer. Any low iron in a male patient of this age needs to have a FIT test done and needs to have that ruled out. And then I also did an ova and parasite testing because he wasn't born in Canada and had some exposures, though no symptoms from that. And there can be more than one thing going on at once. So this has now changed. I just wanted to point out that it would have been the infectious diarrhea panel that I would have ordered for this patient, and it would have covered everything that I needed if the celiac testing had come back negative, if the FIT was negative, if everything in the infectious diarrhea panel was negative, then I very likely would have gone on to order a stool microscopy for protozoan and worms, because that would have given me a broader spectrum of organisms and also helped me to start to look at other things that could have been the cause for this patient. But thankfully, his anti-TTG was positive, and all the other testing that you saw previously, so the FIT and the ova and parasite test, was negative. So what did I do? At the follow-up visit, I discussed the pathophysiology of celiac disease, and I referred him to a walk-in with blood work results and a list of symptoms sort of in hand, and explained what the next steps would be. Now, in looking back at this case, I probably would still include a referral letter, just a summary of the blood work, a summary of the symptoms, for completeness, for professionalism. But at this time, it just seemed so obvious. If you showed the blood work, if you lifted up your shirt, you sort of knew what was going on at that time. But I would change that to sort of adding in a referral letter now. And then I explained what we would need to continue to monitor moving forward, and why, whether it's myself, whether it's the walk-in doctor because he didn't have a GP, whether it was a gastroenterologist that he was referred to, but that these were the tests that would be important to do moving forward. His iron, his B12, his zinc and copper, and then also his thyroid. There is an association between celiac disease and thyroid conditions, and actually the last case that I'll talk about today has an association there. So it's important just to continue to monitor that. And then I gave him a resource, because all of this was so new to him. So he didn't know that celiac disease existed. There was no family history of it. He was having gluten, of course, in his diet. And I find when you're the person that's making the autoimmune diagnosis for a patient, it can be very overwhelming. So I'll often always send them with something, a resource that I trust, not something that they Google, that's maybe not a reputable or reliable source, so that they can continue reading about it and I know what they're reading. And then I discussed common and hidden sources of gluten and how we approach it from a naturopathic perspective. Now, he was really here for fertility, so we also kind of started to look at that and shifting that. And he was just so happy with the diagnosis and with the referral and with some answers to this long-standing health concern that I didn't follow up with him as much as actually his wife, and kind of got updates through her about how he was doing. Of course, they both consented to that. And I do have a plan sort of that I'll go through next about what I typically do, but this isn't something that I did with him as an example. Sometimes we get to follow patients all the way through their autoimmune diagnosis and journey, and sometimes it's just the person that does the physical exam, that does the labs, that gets them started and changes, course corrects for them. One thing that I wanted to mention before I get to that, though, is that it is important that a patient consumes gluten prior to any anti-TTG testing. And I'm often asked about the minimal amount for patients where they maybe have an awareness that they might have celiac disease. So in this case, he was ingesting gluten. There was no need to make any specific recommendations. But in other patients that may be more mindful and already starting to remove gluten sort of from their diet, the minimal amount of gluten ingestion prior to testing an anti-TTG is 3 grams per day, which is equivalent to 1.5 slices of bread for 2 weeks. And if the patient is able to continue, you would continue for 6 weeks. If they're not able to continue, you would perform the serologies. And if the serologies are negative, then the gluten challenge should be continued again if tolerated and repeated after 8 weeks. So 12 weeks from the start of the challenge. And if the TTG is negative at this point, celiac disease is unlikely, but the goal would likely be to still have them follow up with a gastroenterologist to assess the value of a gastroscopy. And if a patient is continuing, if on a gluten-free diet, this is important, sometimes you can have performed, because we don't have access to this as naturopathic doctors, an HLA-DQ2 and HLA-DQ8. And if they're both negative, that can rule out celiac disease, but they can only be used to rule out celiac disease. So I often get a lot of questions about that from patients. So I just wanted to review that portion as well. And this is a sample plan that I'll often do with patients, and that I actually did with the last patient that we'll speak about. A really strict gluten removal. I'll often recommend that the household goes gluten-free if that doesn't create more stress. And I'm also mindful of letting them know that I don't prefer that they rely on gluten-free products. I would prefer if they use that in a pinch, sort of here and there, but not necessarily daily use because of all the sugars and fillers that are added to those products. And as they start to get more comfortable with the diagnosis, then I'll start looking at hidden sources, because I find it so overwhelming for patients at the beginning, and they almost get paralyzed or hyper-focused, and we don't want that stress for their gut either. So then I'll start discussing, malt and salt and vinegar chips, not shopping it from bulk bins, asking, do you use a mouthwash? What is your toothpaste? What is your shampoo? Let's have a look at your medications. What about oak red wine? And then I'll often have them on a gut healing protocol that includes L-glutamine and demulcents and digestive enzymes to start. And the dosing of L-glutamine that I typically use is 5 grams an hour before food or 1.5 hours after food, once daily. And then depending on how they respond, we may do a couple rounds of that. And then the digestive enzymes I have them have with each meal, so that we kind of give their digestive system a bit of a break. And we'll talk about populating the healthy flora in the gut with soluble fiber and probiotics as well. So things like chia, psyllium, lentils, beans. I do have patients with celiac disease soak lentils and beans prior to cooking, just so that it helps with another breakdown process and is a little bit easier on their gut overall. So that was the first case, a really important lesson for me in being thorough and really making sure that I'm practicing inclusive medicine. So if I see this rash on another patient with a very different history or atypical celiac history, I can recognize what it is. The next case was a case of a 60-year-old female who came in with a diagnosis of osteoporosis from her medical doctor. No pharmaceuticals were prescribed or needed at this time, and she was looking for guidance on navigating this new diagnosis because she unfortunately didn't feel supported with this diagnosis currently. So these are the labs that she came in with from her family doctor. So you can see that the white blood cells are a little bit low. And then in her hematology, it was fine tooth combing through it. And her MCV and MCH are a little bit on the high end of the range there. And her ferritin was 347, so also elevated. she reported that she had been iron deficient and even anemic her whole life, and she had been on iron supplementation, and she continued that through menopause. So had been continuing that for the 8 or so years that she had been in menopause. So we thought potentially that could have been related to that. And then her blood work also showed some dyslipidemia, and her thyroid was checked. I'll always check the thyroid when there's any dyslipidemia because it needs to be optimal in order for our body's metabolism, including the metabolism of lipids, to be optimal. So there were no issues with her thyroid. And then there were no issues with blood sugar, kidney function, liver enzymes. So everything was good there. So I said, okay, I'd like you to go in with the requisition from your family doctor that includes the ferritin, the fasting blood glucose, the hemoglobin A1C, and a repeat lipid panel. But I would also like you to take this requisition with you and have it done at the same time. So I'd like you I'd like to do your B12. And I explained that that was because I wanted to determine if there was a cause of the elevated MCV and MCH. And then the apolipoprotein A1 and B100, because I wanted to know how aggressively we wanted to treat her dyslipidemia. She was very healthy otherwise. She was a non-smoker. She had a whole foods-based diet, very minimal alcohol intake, was very active. But I wanted, and they weren't hugely elevated as you saw, but I just wanted to gather more information about that. And then I also ordered a CRP. And the reason why I ordered, specifically it was an HS CRP, the reason why I ordered that was because I wanted to know for sure that we could trust the ferritin. So CRP and ferritin are acute phase reactants. So if CRP is high, then ferritin goes high. And the latest paper that I've read sort of about CRP and ferritin is generally previously what I'd learned is if ferritin is elevated, if CRP is elevated, then we divide ferritin by about 3 to get the actual ferritin value that's there if it's due to inflammation. But the recent paper that I've read is that it has actually an even stronger association. So the more the CRP is elevated, the more ferritin is actually elevated. So there's a stronger relationship between the two. And I just wanted to make sure that it was due to supplementation and not due to inflammation. And then I ordered the anti-TTG. The reason for that is because we wouldn't have expected her ferritin to be high. We would have expected it to be quite low. But if she had an absorption issue and her B12 is potentially low, and that's the cause of the elevated MCV and MCH, could this be an odd or atypical presentation of celiac disease? So I added that on because I didn't want to send her to the lab again when she'd already gone once and was going to go with a requisition with her MD. I wanted to kind of group it all together so that she could get it all done at the same time. And this is what her labs showed. So I had asked her to stop her her iron supplementation. So her ferritin was good. It was already starting to come down. Her fasting blood sugar and her hemoglobin A1C continued to remain stable. They weren't elevated previously, so that was great. Her lipids had already started changing with some changes that she had made and that we had discussed as well. Her triglycerides were good. Her HDL cholesterol was good. Everything in terms of her cholesterol panel I wasn't as worried about. And this was also because her ApoA1 and B100 were also very good. So I wasn't as worried about her lipids as I was about her B12 and what was going on there. So you can see it's very, very, very low. And her CRP is very low. So I knew that I could probably trust the ferritin now, and it was likely due to oversupplementation. And we would just continue to monitor to make sure that it came down, because unfortunately, there are certain cancers that are related to an elevated ferritin, and so I would want to monitor that. The B12 level that you see here was something that I asked further questions about before testing. So I said, you've never been on a proton pump inhibitor or an H2 blocker for greater than 12 months. You've never been on metformin for more than 4 months. Alcohol you reported is low now. Has it always been low? You've never been vegan or vegetarian. Of course, that wouldn't make sense because her ferritin was high, but just ruling that out anyways. You've never been diagnosed with IBD or had any resections of the bowel or tapeworm infection. And she said, no, 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 no to everything. So I said, okay, I would like to order an antibody test to determine if this B12 deficiency is due to something so this is the antibody testing called pernicious anemia, and it was positive. So I explained what pernicious anemia was, and as a little refresher, it's destruction. It's an autoimmune destruction of the parietal cells, which secrete intrinsic factor, or the development of autoantibodies against intrinsic factor itself. And we need intrinsic factor to absorb B12, which is where the B12 deficiency comes from. And the big sort of take home from this case was, I guess, the thoroughness in reviewing labs, because her numbers weren't out of range. They were just high normal. But it was sort of because of fine-tooth combing her labs that I was sort of able to say, like, this should be tested, and it hasn't been tested previously. And then the B12 was low, and then we were sort of able to get to this diagnosis. So what did we do? I, again, provided a handout for her because, again, I find for autoimmune conditions, it can be very overwhelming for patients. And we discussed weekly benign B12 injections for 4 weeks and then follow-up blood work. And the other thing that was interesting with this case is that this patient had no symptoms. So I had also asked at the follow-up if she had peripheral neuropathy, glossitis, notice any skin changes and hyperpigmentation or vitiligo, mood, irritability, gait abnormalities, loss of sense of smell or vibratory sense. And she said no to everything. So it was a really good reminder, again, to be really thorough in sort of looking at labs. These were her follow-up labs. So her white blood cells had shifted a little bit, actually, which was great. And then her B12 was now well within range after that, after those injections. I wanted to have her continue with 2 more benign B12 injections just to fully optimize her until we said, okay, let's move on to oral maintenance. And at the time, I had her on B12 just on its own, methylated. But I have since found a product that has a combination B9, B12, which I've switched a lot of patients, including this patient with pernicious anemia too, because wherever we need B12, we need B9, and I don't want to give too much of one and create a deficiency in another. I just didn't know of a product that would have that in the right doses sort of at that time. So she's since been switched over, and we monitored her levels for every 3 to 4 months for about a year. And then we're just checking yearly now. And we're continuing to monitor her ferritin because, again, I just want to make sure that that continues to come down as she continues to not supplement as well. So that was the case of pernicious anemia. And this is the last case. So this was a 49-year-old female who came in with a diagnosis of Graves' disease. She had been diagnosed just on routine blood work. So she just went into the doctor, had routine blood work done. It was found, and then she was referred to an endocrinologist. And she came to me because she said, I'm not interested in the pharmaceutical intervention that the endocrinologist had outlined. I'm very sensitive to pharmaceutical medications, and I would like to pursue a naturopathic approach. Of note, this is the patient that also has celiac disease as well. And just as another, not to overcomplicate things, but Graves' disease is also more associated with H. pylori infections. So I won't talk about it in this presentation, but I also had tested her for that down the road to see if there was an immune trigger and to make sure that we weren't just attributing a lot of deficiencies to her celiac disease. So I said, okay, let's have a look at your labs. So the lab investigation that was done by her family doctor and that she brought into office clearly showed a very suppressed TSH and then a T4 and a T3 on the higher end of the range. So I said, okay, let's go ahead and treat this. And I split this entire treatment plan over the course of 2 visits because it would be very overwhelming to do all at once. So the first thing that I did is I started her on an antithyroid tincture, which included lycopus, melissa, crataegus, and scutellaria. So 2 herbs for that thyroid piece and 2 other herbs for the nervous system and heart piece being in that overdrive state. I won't give you, I have the exact recipe if anybody wants that, but when you see towards the end of the case, I actually modified this tincture a few times, and I'll give you that recipe because that's really what I would have maybe started with now moving through this case with this patient and having more experience under my belt. So that was the tincture. And then I also added in low dose naltrexone. The way that low dose naltrexone works in this case is that it's a transient opioid receptor blocker, and it reduces inflammatory cytokines that are potentially implicated in Graves' disease. And T regulatory cells increase via the endorphin release that LDN causes. And when T regulatory cells increase, an autoimmune disease is better regulated. So that's kind of the what I often will explain to patients and why sort of we're using it so that they have an understanding of everything that we're doing. And the dosing for her was a weekly incremental dosing. So 1 milligram for a week, then 2 milligrams for a week, then 3 milligrams for a week, then 4 milligrams for a week, and then refilling a 4.5 milligram capsule that she would continue after that. Although I did, you'll see in the next couple slides, adjust that towards the end. I also started her on some nutrients, specifically vitamin D, because what the research shows is every 5 nanomole per liter increase in serum 25-OH vitamin D concentrations is associated with a 1.5-fold reduction in Graves' disease. So, and there's also an increased TRAb with decreased vitamin D. So there was a few indications for that, let alone the celiac disease portion. And then I added in a multi, which I don't add a lot of or use a lot of in practice, but the rationale was celiac disease and making sure that she's just getting overall nutrition. And then we started on a bit of a gut protocol, similar to what I mentioned with the first case. So adding in demulcents, adding in things to heal the lining and reduce inflammation in terms of the fish oil, and then looking at ensuring that every product that she has is also gluten-free as well. She came in quite educated about celiac disease, but she hadn't done the gut healing, and she also hadn't looked at necessarily products and topical products that could be related or certain hidden products in food. And then we discussed the nervous system. So again, this was split into 2 visits where we talked about what is a message that we can send to a nervous system that may be erratic in the case of celiac disease, in the case of Graves. How can we tell it you're safe? You're grounded, you're stable, you can heal. And so we decided on 10 minutes of deep breathing daily using the Calm app and a little bit of magnesium to help the nervous system just come down into that. I call it that sort of state. And then we said, okay, let's do this and retest in 6 weeks and see where we get. And these were her results 6 weeks later. So the TSH was still suppressed. I expected that. I had let her know that this is going to be a 6 to 8 month minimum journey to get you regulated, and this is going to be the last piece to change. There was an ever so slight improvement in her T4, but there was an elevation, interestingly enough, in her T3. And so I adjusted her tincture and I increased the dose of lycopus and melissa and used those as the main herbs and had that space because I reduced the amount of crataegus and scutellaria in her tincture. And then I also added in acetyl L-carnitine. The way that works is it provides peripheral blockage of thyroid hormone. And I let her know, you might have some nausea, some tummy pain, some headaches. She tolerated it really well, but just letting her know that can happen. And then I also got her moving a little bit. She was very motivated because she had lost a lot of weight because of the Graves, But at the beginning of our protocol and throughout our protocol, I was very clear that symptoms and labs have to change and that we have to be mindful of a thyroid storm. And that's a medical emergency where I would like you to go via ambulance to the ER for. So I said, let's incorporate it, but let's do this gradually. 1 session of cardio in week 1, 2 sessions in the second week, 3 in the third, and making sure that we're monitoring your blood pressure and your heart rate. I don't want you to go above such and such amount. And then this is how her labs changed over the course of us working together. So you can see that the TSH was still suppressed, but the T4 and the T3 continued to shift and get lower. And the thyroid receptor antibody in June of 2022 normalized. So this was about 6 months, I want to say, after we started working together. So it's negative now. And this is the reason why I didn't want to give that recipe of the tincture before, is this is the tincture that I ended up landing on of the lycopus and the melissa, and the amounts. Really strong formulations and really high amounts, but they're very safe herbs to dose at that amount. I also added in a complex homeopathic and then continued the digestive work with phenolics and probiotics and all of those other wonderful pieces. And I do want to say that throughout this protocol, this patient was working with, was following up, I should say, with an endocrinologist. And the first 1 or 2 retests, the endocrinologist had said, your naturopathic doctor doesn't know what she's doing. I would suggest medication. And the patient came to me and said, I trust what you're doing. I would like to continue. And it was her trust in me that allowed me to learn from this case and allowed me to then have the endocrinologist say, actually want you to continue to see your naturopathic doctor. What you're doing is working. And for me, this case was a very important reminder of the potency of our medicine and the sacredness of the patient-doctor relationship. Had that patient not trusted me, we would not get to this place where she was in remission. And I'm very happy to say that she's been in remission since 2023. I continue to see her, and I also treat her 2 daughters now. So this was a really, really wonderful learning experience because, again, this patient allowed me to try, to adjust, to tweak. And throughout the entire time, I was really clear about the rationale behind things, making sure that she was informed, making sure I had her consent, making sure that she was aware of possible side effects of the thyroid storm, and that we weren't doing anything that was unsafe. We were just doing it in a way that's different than what was conventionally recommended. So really, really, really great learning experience. And I'm so grateful to this patient that she put her trust in me. These are the references that I have here. And then I wanted to mention a couple resources that Leanne has attached onto the handout section. So I've attached the up-to-date pernicious anemia handout that I provided to the second patient, as well as a resource for celiac patients to ensure that all of their products are gluten-free. Just information about label reading that sometimes can get missed in their follow-up with a dietitian, or visits can get so big and busy it may be difficult to go through each of those particular words. And then a paper on autoimmune testing. This is a very big paper. It's 89 pages, I want to say, but it has, I think, almost every autoimmune condition and which antibodies you would be testing for that autoimmune condition. And it's very well laid out. It's a wonderful resource, as well as a paper on the use of low-dose naltrexone in practice. And this resource talks about 3 specific conditions. So MS, Crohn's, and I think Graves is the other one. And it talks about what the mechanism of action is. Sometimes I will even give patients this paper if I feel that the information isn't too complex for them. There are some patients that either have a medical background or nursing background that I've given it to that have really appreciated learning more about it before initiating it. And then the last 2 resources that I've listed are resources to kind of diversify how we look at skin and making sure that we're not missing skin conditions on people of color, and starting to kind of retrain our minds about how we view medicine and how we can also view inclusion as well in medicine. And these are some books that I'll often recommend for patients that have autoimmune conditions and in the state where they're unsure sort of what's happening with their health. It's Gabor Mate's When the Body Says No, Pima Children's The Places That Scare You, and then also a book that is wonderful, has wonderful recipes about food-based adaptogen support. It is another area that I'll often support in autoimmune conditions. I haven't talked about it in this presentation, but often another tenet or pillar will be to make a person stronger so that they can deal with the autoimmune condition better. So those are some other resources that I give to patients. And the last thing that I wanted to say before I take questions is that for patients that have autoimmune conditions, it's often this time of their whole world is flipped upside down, right? It's often this time of the unknown, a lack of control, fear, uncertainty. And I try as much as possible in these cases to make sure that maybe a patient won't remember what I've said, everything fully. That'll be in the treatment plan. They'll get a copy of that. But how am I leaving them feeling? Are they feeling safer than when they came in? Are they feeling more supported than when they came in? And are they feeling more encouraged and less hopeless than when they came in? And if I've done that, I know that we sort of open the door to healing. So that's the last piece that I sort of wanted to mention that isn't necessarily lab related, but a really big focus of mine in practice. I hope that this was helpful, and I hope that you've all learned something that you can take into practice, and I'm happy to take some questions now, Leanne.
Thank you, Dr. Rama. That was amazing. There are just a few questions.
Sure.
The first one was a comment. The first case, just in my opinion, the saturation and iron are both low and suboptimal. I think actually you had said the same thing after anyways. Okay.
Yeah, just to clarify for that one, not abnormally, where you would maybe if you had just done that, known for sure, yes, there's an autoimmune disease here. But yeah, really good comment, I would say. It's not optimal for sure. Just not red flag the way I would say it.
The first question is on case number 3. T3 and T4 were in range. Was she symptomatic?
Oh, sorry if I didn't mention that. Yeah, so this patient was not symptomatic at all throughout. So from the very beginning when she first came to see me, we never had any issues with thyroid storm or any issues related to that. I will say that there was a time where her blood pressure was a little bit off. We just monitored it. It was kind of a little bit erratic, but nothing where we had to use any medication or beta blockers or anything like that. But throughout was thankfully really stable and very asymptomatic.
Okay, thank you. For slippery elm, what form do you have patients get from local stores? And do you have them do gruel or in warm drinks?
Mm-hmm. The slippery elm is so polarizing. Hey, we at our clinic have a slippery elm powder. So I like the powder form, and I have, for compliance, patients mix it into unsweetened applesauce and just take that. So whether it's kiddos or whether it's adults, that's the best in terms of compliance. I myself like to have it in the form of adding a little bit of water, mixing it up really well, adding more, and kind of sipping it as a tea. But I also understand that that taste is polarizing and that it can be a little bit hamster cagey is the way that I describe it sometimes to patients. So that's the easiest way. I would say I do like it in the that powder form, because I want it to contact everything on the way down. And of course, a capsule will open up later on in the digestive tract.
Okay, so in the applesauce.
Mm-hmm.
What if B12 levels are too high? Are you concerned about it?
Yeah, I'll still chase that for sure to make sure that there isn't going on there. And the big things that I will look at for that are homocysteine, MMA, and that cycle that we sort of see in school, and making sure that there isn't something that's related to why that is. If there isn't any supplementation, if that's elevated, could that be an indicator of homocysteine and heart health or something else? I will still check that and go after that.
Okay, thank you. Next one, as a practitioner, I am interested in developing my knowledge base to support patients living with autoimmune disease. Are there additional resources you would recommend, like seminars, books, or people?
Oh, I really think that the paper that I provide is a really good resource. I don't think you can necessarily get better than that, to be honest, to accurately diagnose patients. Again, it has the autoimmune condition and then the specific antibodies that you would want to test for that. I mean, the first thing I find is not having patient symptoms dismissed, getting an accurate diagnosis so that you can start on that path. So that would be one of the resources. And then Gabor Mate has some good information. Irene Lyon has some really good nervous system courses. What else? I think for me, it's just been a collection of many different books and papers and seminars. Nothing specific that I can say, was groundbreaking, more a collection of all of these pieces. And then in continuing to work with patients with autoimmune conditions, you also learn, okay, that's overwhelming, let's adjust this. Okay, that works really well. This is, kind of a dosing where it tends to be that LDN dosing that's a really nice level. There's just the tweaking that sort of happens with experience. But the books and the papers, Irene Lyon, Gabor Mate, those are some good starting points, I would say.
Okay, thank you. Last one here. For blood work, how recent does it have to be for you to consider the results valid in order to diagnose? How often do you retest for case number 3?
Oh, sorry if that was confusing. That was a case from 2022, where I also saw her in 2022. So I don't know if that was where the question was related. And then I like blood work in the last 3 months, because if there's if they're diagnosed with Graves' disease, there hasn't been an intervention, they're coming to me, like that's likely blood work that I can trust in the last 3 months. And then the testing for the thyroid has to be every 6 to 8 weeks, because it's not going to change. It's too early essentially to change before that. So that's if somebody has hypothyroidism and we're prescribing Synthroid, or if somebody has Graves' disease and we're trying to normalize the thyroid, both matter. It has to be that 6 to 8 week mark.
Okay, perfect. Well, I think that's the end of the questions. I'm just going to go back to the chat to see.
Sure.
Oh, it says, great catch on the pernicious anemia.
Oh, pernicious anemia, yeah.
Pernicious anemia, thank you. Was there any other symptom that cued you to test for parietal cell antibodies beyond the very low B12?
None. Like I mentioned, she was completely asymptomatic. So no swollen tongue, no peripheral neuropathy, no skin condition changes, gait abnormalities, mood, nothing at all. And also, she was a very healthy individual. So had I not combed through her blood work, there wouldn't have been anything that would have cued me to check that. So I was glad that we had the CBC for that case, because maybe I wouldn't have. I like checking B12 for people. I would say overall, I find it's a big nutrient that improves energy. It's so needed for like metabolism and many different things. I maybe would have tested it, but had there not been a CBC, because there were no symptoms, I may also have missed it as well.
Okay, thank you. And Rianne Goluska says, hi, Kristal.
Oh, hi. I miss you. I'll text you.
Awesome. Well, thank you very much for that informative session, Dr. Rama. Everyone, if you stay on just for a few minutes while the webinar closes, it will redirect you to the contest page. All 3 secret words are out, and the winner When I send out the follow-up email, it will list the winners and I'll send the gift cards via email. So thank you again, Dr. Rama.
Thank you so much. And thank you to Life Labs for letting me share this presentation. I'm so passionate about autoimmune conditions and helping patients with them. And I hope that some of this information helps more people. That's the goal. So thank you so much.
Oh, that's great. Someone else just said they would love more classes from you. So
Aw, that's so sweet. Thank you for whoever said that. I appreciate it.
it was Dharm Sidhu.
Aw, thank you, Dharm.
Okay, well, have a good rest of your day, everyone.
Bye.